How much do you do in the realm of microbiome and trying to, in a targeted way, measure, change microbiome?
That's a tricky one. I mean, I do these specialized stool tests. I call it the fine-tooth comb stool test because we get these 5 pages of paper on markers for digestion and absorption and these, DNA analysis of the microbiome. And I go through those with my patients and I say, okay, here's your PCR analysis of your microbiome. And I'm like, I'm not saying that we're going to say, here, this one's low and that one's high, and we're going to do this for this or that. We look at it kind of as an overarching look. Okay, this is why there's maybe some imbalance and dysbiosis. There's a few key things I look at, kind of the top 3, what I call the big 3, E. coli, Bifidobacter, and Lactobacillus. And I kind of see, are those there in the PCR? Because then we see, do they grow in culture? So I look at it from that perspective. I look at kind of the metabolic function of that, how much short chain fatty acid they're making, from that. So just to kind of get a picture of it. And are there opportunistic, bacteria there, which are normally found in the gut, but in such high levels that they're kind of a potential pathogen.
Right.
So,
and do you do that for everybody or only for people who have, some reason to think that there's digestive gut stuff going on?
It'd be fun to do it on everyone. But insurance doesn't pay for that.
Sure, right.
It can be kind of pricey to do that stuff. So it's a targeted audience, right?
Yep.
So I'm more likely to find an issue because we're testing for a reason to figure out what's going on here.
Right.
So then the approach to that is, in naturopathic medicine, we've always talked about these sort of, I think it's called the 4 R's. It's remove, replace, restore, repopulate. Sort of, do you remove or go through your kill to reduce some of those overgrown bacteria? And then how do you restore, digestive function by digestive enzymes or support, function of digestive enzymes by either, bitters and that sort of thing to try to get that to happen naturally. And then probiotics to potentially repopulate. And then, the fibers and things like that to actually keep that going.
And this is just my personal sort of curiosity. Where do you fall prebiotics versus probiotics? So prebiotics, of course, being fibers and chia seeds and, the things that you can use. And then probiotics being supplement with like the yeast species or bacterial species. Where do you sort of, I'm assuming that you're going to say there's appropriate uses for both. Yeah. But where do you sort of fall in the balance?
I think the variety of fibers and prebiotics are key to maintaining like that diversity in the microbiome. So I'm more about people getting prebiotics in their diet as much as possible. Yep. But if there's a lot of like what we refer to as dysbiosis or imbalance in the microbiome, a lot of that prebiotic stuff is going to cause some problems. Usually a lot of gas and bloating.
Especially at first until you can sort of restore balance.
Right. Yeah. So, usually approaches probably start with the probiotics, try to kind of see if you can affect a change there. And then maybe later put on more of the prebiotics.
Yeah.
So I think to maintain gut health, it's more of those fermented cultured foods and your variety of fibers.
Right. I think what you said is actually really important. And, there's many reasons why going from, very low quality diet to a very high quality diet is difficult. But on top of, the habit change and behavior change and all the other stuff, I think what you just said is something I hadn't really thought about, which is that there's also going to be potentially digestive consequences. It's kind of obvious, but, if you just make a rapid change, that actually can lead to negative symptoms from the change in the fiber in the diet, for example, which is going to make it less likely that people are going to want to stick with that new dietary habit. And so if you can accommodate that with a probiotic, that can help with the behavior change. So I think this is actually something that's probably valuable to think about. I've sort of, my personal bias has been away from probiotics, in part because I'm not convinced that a lot of the products out there actually do anything. It's very much like the supplement industry. So whereas, if you can increase the variety and amount of fiber that you're getting in your diet, that's going to move the needle, right?
Probably.
Well, it will, but it might also have some other consequences that you want to avoid.
I mean, so do you slowly change it over?
Yeah.
Can you tolerate that? Or is there really potential pathogenic stuff where you maybe want to do some antibacterial herbal formulas and stuff and kind of clean some of that out? Or you're just going to get more of the same? Like, and there's this condition that most people have heard of because I think it's pretty well known, called small intestinal bacterial overgrowth.
Yeah.
And if you just start adding a bunch of fiber to that, you're just going to make that a lot worse. And you're not going to slowly get better as you add more fiber. It's just going to stay that way.
Continue to cause maybe.
So you'll
even
never
cause
be
things
able to do
worse.
that until you treat that condition.
Right.
Yeah.
Right. So it's very individual dependent. Yeah, for sure. So, and do you have a microbiome? So the test that you use, is it a clinical test or is it something that is like direct to consumer?
I don't know if there might be direct to consumer. I've used a lab called Genova Diagnostics for years, and they have a test called the GI-FX test or GI function, different levels of it. It seems to be pretty good. There's another one that I've used before that might be a little too sensitive and show up stuff that might not really be an issue.
Yeah,
so.
And I mean, I think especially in the microbiome space, there's so much stuff that we can measure that, but we don't know what it means. Right?
Exactly. Like
so
there's all
you get
this,
overloaded with information.
The microbiome causes this, and the microbiome, and there's connections, but we're kind of like, okay,
what does it tell us?
What can we really do specifically? But there is actually, we were saying, like sort of probiotics. There is actually a company that is out of Germany, it might be Austria, that has a really interesting different probiotics, and they have functional MRI studies on brain changes with some of their strains. So they have actually human studies. They're not just looking at other studies and using it to make their product. There actually is a pretty good product out there. They have different ones that we use.
Yeah, and there's no question, right, that changing the microbiome, the gut microbiome, and the reason why I specifically say the gut microbiome is we tend to ignore the other microbial populations in our bodies, which are important too. But that they can have systemic effects far beyond what you would expect, right? And that can be from changes in inflammation or metabolites that are produced by the bacterial species that
brain
get
chemistry.
Into circulation and can cause metabolic or signaling consequences. So absolutely. I guess the one reason also why I'm a little bit cautious about just mucking around with the microbiome is we understand it at such a crude level that there are some risks of the unknown that go along. And I mean, I won't call out the specific company, but there's a company that's got a very specific product that increases the amount of a very specific microbial species that potentially won't change. And while they believe there are a lot of benefits that go along with increasing the specific microbial species, there could be some consequences that are detrimental. And I don't really view, this is where I think there's a little bit of a disconnect in regulation, is I don't really view probiotics that do in fact alter the gut microbiome any different from small molecule drugs that change the activity of a protein. They change biological function and physiology in complicated ways, sometimes permanently.
Right.
And yet we don't regulate the probiotics at all until somebody dies. And we really regulate pharmaceutical medications, and then supplements are kind of somewhere in the middle, right? So it's this weird disconnect between the use of these things.
Yeah, and I think the single instrument in a symphony of millions.
Right.
It may be an important one, but if you're just doing that one.
Yeah, I mean, if you're taking a probiotic supplement that is meant to mimic more or less what we think is a healthy microbial community, that's less likely to have, significant consequences one way or the other, in my view, unless you're really dysregulated, in which case, if you can restore the appropriate balance, it can have pretty positive benefits. Yeah. So anyways, it's a super, super interesting area. I think there's tons of power in modulating the microbiome in targeted ways, but
There's
it's
way
still
more
pretty
than,
early.
Yeah, there's way more than we don't know than what we do know.
Right.
But the hints are like, it's hinting at like, major influence.
And historically understudied, which is why we don't know as much as we probably should.
Totally, yeah.
So speaking of things that we don't know or we aren't sure about, I mean, I know there's a couple of things that I would characterize maybe as a little bit more experimental that your practice utilizes, like PRP. So can we talk about that, and like, what do you think about that? How do you use it? How don't you use it?
So I personally don't do PRP in it's not my skill set, but we do have docs in our office that do it. And it can be really helpful for healing of, tendon tissue and
Can you just describe it for people who may not know what PRP is?
So it stands for platelet-rich plasma.
Right.
And so what happens is, if you have a musculoskeletal injury, usually like a tendonitis or even maybe a minor tear in a tendon or something like that, it's a regenerative injection therapy. So you as the patient would have your blood drawn, quite a few tubes actually, and that blood is then spun down to concentrate it for the platelet-rich plasma in your blood.
Right.
And that is actually then extracted and mixed with a few little growth factors, not exactly sure exactly what they are. And then that formula is used to inject to that injured tissue.
Right.
And my understanding of how that actually works, and it's kind of, I don't know exactly, the terminology, but it really just kind of upregulates really an inflammatory response, because you really can't take anti-inflammatories after you have this done, because you need that inflammation to come in and then and just rev up the healing of those tissues. So you're getting some.
So I think this is where the word inflammation can mean. I mean, it can mean all sorts of stuff, right?
Right.
In this case, it's a type of inflammatory response that is going to promote healing, as opposed to other types of inflammatory response that can actually impair wound healing.
And my colleague who's done this quite a bit, he described it to me, I think, is a nice way to think about it. You have this sort of chronic kind of non-healing area, like a tendonitis or something like that. He described it as this low-level inflammation. And he says it's kind of like you're trying to bake a cake in an oven that's not hot enough. And so if you can turn up that heat, you'll finally finish baking the cake and you'll, finish out the process. That's kind of how he describes it. So do you really need platelet-rich plasma to do that? Can you just go in there with something called prolotherapy, which is just, you're kind of just irritating the tissue with, I think, a little bit of dextrose, injecting, and turning up the heat that way. I've had that done. It worked quite well.
Really?
In my elbow. Or do you need to go all the way to stem cells? So it's kind of like you're trying to go to the same location. Can you do it in a Ford Taurus or, a Cadillac or a Ferrari?
Right.
Because that's really the cost that you're thinking about, because I don't think many of these things are really covered by insurance.
Right.
I think. Yeah. So, but PRP tends to be, I think people like PRP because I think you're getting some growth factors out of that platelet-rich plasma to maybe actually get a little bit more.
So the prolotherapy,
is
that an FDA approved therapy, or is it?
I don't know, because I don't know enough. I don't do it, but I mean,
But you had it done.
I had it done. I mean, we doctors, we do all sorts of stuff on each other, right?
I can totally see I don't know if I've told you this story, but I've told it before in different contexts where the first time I took rapamycin is because I had frozen shoulder.
Oh, okay.
And it just, there was the physical therapy wasn't working. The doc didn't want to do, an injection into the joint.
Sure.
And so I was like, I can't live like this. This has a good chance of working. I'll give it a try. Right. So I totally get it.
And it worked?
Oh, yeah.
Oh, cool.
Yeah.
Yeah. And that's what I think about with these regenerative injections. It's called regenerative injection therapy, typically, that group of that kind of those injections, might help, can't hurt, or might not hurt. I mean, I'm sure like any procedure you can have, obviously it could go wrong, but it's kind of a low risk thing. And can you get the needle to move and get the tissues to heal without going in there and doing a surgical procedure?
And let me ask you, so with the PRP, is that all done in your clinic, in the same clinic? Because it sounds like this is stuff that can all be done because you take the patient's samples, you're going to process those, and then put them back in the patient.
We
as
have
opposed to
a
like a lot of the stem cell therapies, which often aren't regulated. You don't know where did those stem cells come from.
Right.
Is it a reputable source? That's where I have a little bit of worry in the stem cell world.
Yeah, I think, so yes, we have this special centrifuge because it needs to be spun at a certain RPM, or what do you call it? And it's all done in a hood.
And can that be done in the same day? Like somebody comes in?
Oh, you have to do it in the same day. So you're there for a while.
Yeah.
Because then your blood has to be spun down, processed, and then pulled off and all of that. So, you're not there for hours, but maybe a couple of hours because you've got to have your blood drawn, and then we have to process it. Not me, but they process it, and then they put in the syringes and go for it. So it can be done in office. We did it. There's this thing called it's Halloween vampire facial. It's Halloween, right?
It is, yeah.
Right?
I forgot to wear my costume.
Right.
Oh my God.
So actually, it's a PRP facial. So we've actually played around with this in our office. We have it's a microneedling where you're just doing, tiny little pricks in the skin and you're kind of damaging the skin a little bit to allow whatever you're putting on the skin to penetrate.
Sure.
And we've done that with PRP.
Huh.
So we've done that before. So it can be done in the cosmetic world. I'm not so sure how much that really gets into the skin, but it can be done topically. PRP is also done for like hair loss or hair restoration. I think it's kind of all of this may work and may not work.
Yeah, this is one of the challenges is because of the way and that's why I led this with things that may or may not actually, it's unclear whether they work sometimes because we don't have the studies and because of the way they're used now, it's unlikely that we're going to get the, randomized placebo-controlled, clinical trials because there's no incentive structure for those trials, right? Because people are already using it.
Right. Well, yeah. And I think and in my experience, I see patients, oh yeah, I had that done. It didn't do anything. Yeah, I had that done. It was amazing. And I'm always wondering, okay, how do we how can we predict who's going to respond well to this? There's something about who's a responder and who's not a responder. And that's, I think, what we don't know right now.
Right.
But,
what's your gut feel? So, I think part of it is also what you're using it for. Because like with my shoulder, the effects were so profound. It went from I couldn't sleep, I couldn't throw a ball with my son to 10 weeks later, I was 95% back to normal.
Yeah.
It was obvious that it worked. And could it have been placebo effect? Obviously, there's a chance. But in that situation, it's unlikely because of the severity of the symptoms and the biological plausibility of the mechanisms.
Yeah.
So I think there are cases where you can be confident on a case report, sort of anecdotal, this worked for this person.
Right.
But then when you're talking about the facial, how do you measure that, right? Is it how many times did you go home and your spouse said, wow, you look great? So what's the quantitative thing you're measuring to know whether it worked or not? And how many times do
you have to do it? And,
So it's harder to know with things like that.
But even for the musculoskeletal stuff, why do some people have zero response to PRP and why do other people have a great response? And I think there's something, I think there's a better way to choose people who are candidates.
Yeah.
And maybe some really astute, docs that do that kind of work are kind of starting to get a sense of who's going to, they want good numbers.
Right.
So you're going to pick your person who you're more likely going to respond, right?
Right.
They want to have a good result.
I guess the question would be, are there mechanisms for capturing that information in some way that it can help other providers and the community at large have confidence in a procedure like this?
Yeah, I don't know.
I know you can go to conferences and talk to people, but I also know a lot of these conferences, people get up and they talk about their latest, greatest thing they're trying to sell, right? So,
right. I think, just, common sense is if someone is a smoker and, and is just not in great health to begin with, they're possibly not going to do really well. They're not going to really heal well just because of all that, right? So if you have all those foundational things taken care of, then you're maybe putting someone in a better position.
Yes, of course.
To be successful.
And you can't really go wrong with cleaning some of that stuff up.
Right. And maybe they get better in other ways just because of that.
Yeah.
I think these docs that are doing all this should probably get together and figure out, okay, what are they starting to see trend wise? Are there some commonalities between those people who really respond?
Yeah.
Is it an age thing? Could be, right? And
And what sort of related, I don't want to spend too much time on this, but what do you think about some of these peptides? Because peptides are a big deal now, healing peptides. Do you have any experience there? Any thoughts?
I've played around with peptides a little bit. Obviously, the main peptide that everybody's talking about is the GLP-1s and the
Sure, of
GPs
course.
and that sort of thing.
Yeah. And I think most people don't really, they think of that different from even though it is a peptide.
BPC-157 or CJC or like sirolimus.
So GLP-1 agonists, let's start there. Those work. Any thoughts beyond that?
beyond GLP-1s that work?
No, they do work. I mean,
they do work. Yeah. I mean, I think, I think the peptide that I really do like is BPC-157, and I'm not sure if it is still available. I don't think it's available for injection right now, but maybe oral.
Yeah, I mean, this is, again, the regulatory space around this is weird and changing, and I don't know the answer.
Yeah.
Other than I know there are still people getting it and taking it.
Yeah.
I don't know if they're doing that. I don't know the answer to the regulatory piece.
I think gut healing, it's a big one for gut healing.
So you use it sometimes or you have used it in the past with your clients?
We've used it orally, and I think with oral, you're really only going to probably get more gut support for it. I don't really think of oral BPC for someone for healing from surgery or healing, that's usually injecting around the area. Maybe not even necessary around the area.
Right.
I don't know. Those interesting,
I've just started to look into this.
Studies.
So we'll do a deep dive as one of our episodes. I've just started, and I started by going back to where did this come from, right? What were the first studies? There were rat studies in the 1980s or 1990s.
On BBC?
Yeah, that's kind of where it started. Yeah, exactly.
Yeah.
And so I don't know enough about the literature, broadly speaking. And I feel like we still don't have a great feeling for mechanism, like at a molecular level.
Right.
What's it signaling through? What's the co-receptor at that level? I feel like, and maybe I'm wrong. This is where
I don't know.
If I'm wrong, somebody will tell me, I'm sure.
Yeah.
But I feel like I need to do a deep dive to really understand how it's working. But it's intriguing.
I think I think there's a decent amount of literature on BPC that's come out of Croatia on the gut.
Yes, absolutely. That's one of the big uses, and it signals there. We know that. So it's a super intriguing molecule. And again, it kind of falls in this class where it's unfortunate that we haven't had more, of the sort of gold standard type of studies to have a lot of confidence.
Yeah.
Because it seems really intriguing, and certainly at the N of 1 level, many people report, pretty profound improvements.
Yeah. I don't see a downside to it other than to your pocketbook if it doesn't work.
Yeah. But where does that come from? Is that comes from experience of not seeing downsides, right?
Yeah, and I don't know any reported downsides.
Okay.
I don't know of any.
Because I always think, this is a peptide hormone, just like GLP-1 agonists, just like other peptide hormones that can certainly have both on and off target effects when you take it orally or by injection.
Yeah.
But I think what you said is certainly valid and valuable, that enough people have been using it that we know there aren't going to be substantial side effects in a large number of people, for sure, at this point.
And I'm not quite understanding why they're going away, why they're being targeted by the FDA.
I think it's probably a control thing, right? So again, I think that, because these are, again, they are clearly biologically relevant molecules with significant biological effects. The way FDA chooses to regulate something as a pharmaceutical medication versus a natural product is arbitrary in many cases. And like in the case of GLP-1 itself, let's just take that, or BPC. It's my understanding, at least, this is a naturally produced peptide hormone. And so in some sense, it's a natural product. It's in all of our bodies. It's no different than NAD. But I think FDA arbitrarily regulates whether something falls into the category of a drug that needs to be regulated versus a natural product in cases like this.
Right.
In part based on sometimes political pressures.
Right.
rather than data around safety. The reality is, I think, and it's fair to say, this is, again, my opinion, not knowing all of the data, is that it is reasonable to say there are still some questions around long-term safety. But that's true for a lot of things that they don't regulate.
Right. And I don't know if you can, maybe I'm wrong, that you can just buy peptides. I've always I'm prescribing them from compounding pharmacies.
That's right.
So it's a prescription item. It's just not coming from a commercial pharmaceutical company.
And it's never gone through the FDA approval process as far as I know.
No.
Right.
No,
so this is where I think this is where partly the FDA probably wants to change the regulatory environment around whether compounding pharmacies can synthesize and or buy synthesized products and put them into compounded medications. Again, I get it. We need to have regulations around this.
Sure.
I just wonder why that's any different than a supplement company buying NMN from China, putting it in a capsule and selling it to people.
Right.
There's no biologically, there's no difference really. They're different molecules.
Sure.
But so I think it's
interesting. It is interesting why they're targeted, because I don't hear of reports of harm.
Yeah. At least with that one. But I think also partly this, and again, this is my own speculation. I don't have any data to back it up. But, the history of performance enhancing drugs and the way those were regulated. And that may also be playing in here, because some of these peptides have fallen into that performance enhancing drug category and are used by, bodybuilders and things like that. So it may be sort of tied up there as well.
Yeah. And I know what they're doing is they're changing the definition of how many amino acids
which again is ridiculous.
Right.
There's no biological reason to do that.
It's a biological substance versus it's a peptide.
Yeah, this is when bureaucrats start trying to do biology.
That's part
it makes no sense.
I think that's part of why I think CJC157, I don't know. I mean, I think people can still get it, but I think they were targeting that because it's more than 14.
Yeah.
I mean, I don't know how many, 40 amino acids. I don't know what they were saying.
Okay. So anyways, BPC is something you've used and you feel has a lot of potential. And
I like it for gut stuff. I don't, like I said, I don't do a lot of orthopedic sort of injections, but I've seen it be helpful. Sometimes they'll mix it in with the PRP or in with the prolotherapy, just to get that extra support on healing.
Interesting. Yeah. And then I think the other topic I really wanted to, there's two more topics I want to do a little bit deeper dive, and they're both big. So let's start with diet. And maybe we won't have to spend a lot of time on this, but I mean, I guess the question I've just got is kind of big picture. What are your recommendations to your patients around nutrition, diet, what diets or dietary strategies? And then do you have a favorite diet, so to speak, and by that I mean like keto or carnivore or so what are your thoughts in that realm, broadly speaking?
So as far as diet, the more the less processed, more whole foods, the better. I mean, it's really kind of common sense. And then
I know it is, and yet
the more the thing looks like how it came in its original packaging as far as from the plant, the better. And so, the more fruits and vegetables you can get in your diet, the better.
Yeah.
The less processed food, the better. So I'm not really hard, fast saying you must eat this way or that way. And
so I think shop around the outside of the grocery store.
Shop around the outside of the grocery store. The whole classic, don't eat too much. Make sure you get plenty of fiber in your diet, decent amounts of protein.
Where do you land on protein? What do you mean by decent amounts? That means different things to different people.
So I mean, it's interesting. I do BIA analysis with patients so we can look at, muscle mass, fat mass, visceral fat, and that sort of thing. And
so BIA impedance analysis.
Bioimpedance analysis, which will then, show you not just weight. I call it the fancy scale because we can see how much is muscle, how much is fat, how much is water, all that. And it's really trying to maintain that muscle mass as you age or maintain that muscle mass as you're losing weight.
Yep. And that's the GLP-1 agonist thing that doesn't get talked about enough, right?
I mean, protein. And I think it is kind of, I think we're starting to kind of see that maybe having more protein as you age is probably a better idea.
Yep.
And so I just do a simple calculation. I try to tell my patients, kind of at least a gram of protein per kilogram of body weight, which is kind of on the lower side to what some people talk about. But probably 1.5 to 2. I think some people are doing it per pound now, like 1 gram per pound of body weight, which is like
that's probably at the high side.
That's I don't even know how you can do that. Like,
I do it.
Yeah, you do. What are you just drinking?
Not intentional.
Are you just drinking protein?
No, actually, I was going to ask, like, what do you recommend for protein? No, I mean, I think so. Certainly, I get a lot of lean meat or fish. I love turkey. I've kind of moved away from chicken. I like turkey a lot better.
I think turkey breast has more protein for
yogurt.
For
so some of the yogurts that are available now have quite a bit of protein. And I actually find I don't really need to supplement protein powder. And I've tried to cut back. I don't eat nearly as much like protein bars or anything like that. So try to get it from whole foods, as you said. Eggs, again, egg whites, great source of protein. And again, it's been a while since I've really tracked my macros, but I was getting close to a pound of protein per pound of body weight.
A gram per pound.
I mean, sorry. Yeah.
A gram per
gram of protein per pound of body weight each day. So somewhere between. So I think if you could do one per kilogram, that's going to put you at like 0.6 or something.
It's not a lot, but
so 0.6 to 1 gram of protein per pound of body weight. Easy rule of thumb.
At least.
Okay.
Yeah. I mean, if you're trying, and then if you're trying to maintain that muscle mass while losing weight, that's like, you really got to work at it and do that resistance training.
Right. That's the other big piece.
Yeah. So, but as far as a type of diet, I really do lean towards sort of the Mediterranean style diet because it's there, it's the most
it's hard to argue
diet.
With, right?
It's the most, I don't know if it's the best diet per se compared to other things, but it's the most studied. With the most positive outcomes. So, and there's a lot of instruction on that. There's a lot of books. There's a lot of, you can just, I don't think we're going to go wrong here.
Right? I mean, I love the way you frame that because I think that's exactly right. It may not be the optimal diet for you. And yet if you just want a rule of thumb, it's the one that we've got the best data for. There's, like you said, there's lots of information. You can find tons of recipes. You can find you can find restaurants that specialize in it, right? So it's, from a pragmatic perspective, it's a great place to start. Yeah.
And then one other thing I really actually try to have my patients do is make sure that they have a decent amount of fasting time each day. And I don't mean during the day. I always try to say, at least like 12 hours from when you last put calories in your mouth to when you first put calories in your mouth.
And is that something you think everybody should do?
When it comes to insulin-degrading enzyme, probably for autophagy. So insulin, I always talk to my patients about this IDE insulin. You've heard of it. Enzyme,
I know it, but go ahead. I don't think everybody would.
So it's got two jobs. So it's an enzyme that breaks down insulin. So when you eat food and your blood sugar goes up, you have to have insulin to get that fuel into your cells. But once that insulin's done doing its job, what does it do now? It gets broken down. So this enzyme breaks it down, and there you go. But that insulin-degrading enzyme has a night job. It's a janitorial job at night. And so it needs to go in and actually help clean out old, cellular debris, stuff from cellular functioning that needs to get cleaned out. So it's called autophagy. I mean, that's kind of my cartoon version of it. But it will never go to the night janitorial job if it's still busy breaking down insulin. So I think you really have to be in a fasted state long enough to allow that to go to the janitorial job.
Yeah. And I mean, 12 hours. So I've got sort of mixed views on fasting. Not so much that I'm against fasting, just I think it gets talked about as if it's a longevity intervention, and the longevity data is where I push back, just because it's really caloric restriction. It seems like in the animal studies. So take that off the table.
Maybe fasting is a way to restrict calories.
It's a difference
to get there, right?
Yes, absolutely. It's a tool for sure for caloric restriction. I do think that there's plenty of evidence that having a fasted period every day has benefits. I'm still not in the camp that like if you're metabolically healthy, body composition is where you want to be, that it is a necessary piece, but I think most people aren't there anyways. And 12 hours, let's be honest, is not a long time.
I don't think 12 hours is a long time, and I think that's enough from what I understand. I think it's enough for that to work.
I think so too, although again, a lot of the data in this space, so autophagy is something that's just hard to measure, like what is productive autophagy, how do we measure it? So a lot of it's a little bit I don't know if sketchy is the right word.
Murky.
Murky. Good word. Yeah, better than sketchy.
Sounds like it's nefarious.
And right. And it's biologically plausible given how we know autophagy works and its connection to mTOR and nutrients. So it makes sense that that's
and I think
there's
12
something there.
12 is easy to do.
Yeah, and it may also be a tool that helps people avoid overeating.
Yeah, and I think I don't know. Maybe is there like data on like late night eating and stuff like that?
You can find data around diet that will support any narrative you want to bring up.
That's true.
Yes, and I'm not sure that all things being equal, I'm super convinced that when you eat. So here's the way I would frame it.
Yeah,
what you eat and how much you eat trumps when you eat every time. But for many people, if you get the what you eat and how much you eat dialed in, the when you eat can be important. And the when you eat can help with certainly how much you eat.
Sure.
So
yes,
I think those are all reasonable things to
I also don't think and you see this all the time, and probably this is the difficulty in studies on nutrition too, that we're so different that not one diet is going to work for everyone.
Yeah.
And you can see that with keto. You can see someone eat like a keto diet and their lipid panel looks fine.
Yeah.
Or maybe better.
Yeah.
And the other person, their LDL goes through the roof, on that high fat diet. So there's
absolutely.
That's a clear example of how it just doesn't work for
especially
everyone.
The more extreme the diet gets, or the more prescribed the diet gets, which is why something like Mediterranean, which has a lot of variability, a lot of variety. I think there are going to be relatively few people where Mediterranean is a bad choice, as opposed to keto, which, like you said, can work really well for some people. But there's also a lot of people where that's clearly a bad choice.
Yeah.
So I think that I tend to be very cautious and skeptical of very rigid prescriptive diets. I don't think there's one that is a good fit for most people.
Sure.
In that.
Yeah, no, I agree.
Yeah.
So I don't get really into a lot of nutritional, advice in that way. Like you must eat this way or that way, unless we're doing something therapeutic where we're having to do a low FODMAP diet to help, support recovery from SIBO or things like that. I usually will then have our nutrition therapist in our office work with someone on what we're trying to dial in.
Can we double click on that? I want you to define SIBO and FODMAP for people.
Okay. SIBO stands for small intestinal bacterial overgrowth.
So we touched on that earlier. Yeah.
And that's just, it's a digestive condition, I guess you call it, where.
How common is it?
I think it's pretty common. I think I've read somewhere where it might explain up to 30 or 40% of all IBS cases, maybe even more. And so it's kind of interesting because we've got this tube, right? And some parts of the tube have a rainforest level of bacteria in it. Other parts of this tube have comparatively like a barren wasteland and not much bacteria. How does the tube do that? How do we keep all that in the place it should be?
Right.
And there are mechanisms by which that happens, but sometimes that becomes disrupted. And so the small intestine should not have much bacteria, and it does have some, but compared to the large intestine, I call it a barren wasteland as far as bacteria. So what then happens, for various reasons, we don't know all of them, people have an overgrowth of bacteria, too much bacteria in the small intestine. Those bacteria now are getting access to foods that you're eating, usually certain carbohydrates, and they will then metabolize those and cause a lot of difficulty with digestion and symptoms of IBS, bloating, gas, diarrhea, constipation, pain. It's a various, depending on, the type of bacteria and what gases they're creating and all of that. So that's what SIBO is. And there's a conversation about how does this happen? How do we get rid of it? What do we do? And it kind of depends on whose church of SIBO you belong to.
I'm non-denominational.
Because you're going to read about do this, don't do this, do that, But and that just tells us how much we don't have it dialed in. I mean, we have kind of some constructs of how to manage this.
And there's probably multiple causes, and I would suspect different flavors of SIBO depending on exactly which bacterial species are there and where in the small intestine this is happening.
Yeah. So that's generally the description of what SIBO is. FODMAP.
So what's the diagnostic test for SIBO?
A breath test.
Okay.
I mean, I think gastric lavage is actually the true test, but that's not available clinically. That's only available in, research. So breath test is kind of what you got available.
And there's nobody has yet developed like a stool microbiome signature for SIBO. It seems like it should be there, but maybe it's hidden, maybe it's buried in all the noise. And
there are patterns we can see in some of these stool tests. If you're kind of astute at looking at patterns.
Yeah. Well, AI is really good. So any of you AI folks out there, maybe you can figure this out.
Well, I think maybe they are doing some of it because sometimes you'll get your report on some of these stool tests and it'll say, consider this, consider SIBO because you'll see this methane score.
Yep.
You'll see, you'll look at the eukaryotic bacteria levels in the PCR analysis. You'll look at fat absorption, is there a little more fat malabsorption? There's a few patterns you can say, this might be that, but it doesn't diagnose it.
Then you would go to the breath test.
Then, and I'm always kind of trying, God, should we just do the breath test or we do this?
And what does the breath test involve?
Yeah, it's basically, I think it's a 6-hour test.
Wow.
So I used to be able to send patients to Children's Hospital to have this done, which was great. Because patients would prepare, I think it's a little bit of a sparse diet the day or so before. You go in fasting, you drink a formula called lactulose. It's kind of a sugar that feeds these bacteria. And then after they do a breath sample first to see, are you breathing out methane or hydrogen? Those are the kind of the top two that are really looked at classically. There's hydrogen sulfate, which sometimes sulfide that some people test for, but it's really those two. So you'll get your breath sample, look for hydrogen or methane, drink the solution. Then every 20 minutes, you're taking a breath sample. And those breath samples are tested for these two gases. And if they go up to a certain level, it's pretty indicative of SIBO. When I used to be able to send patients to Children's Hospital, and then they called me and said, please don't send any more adults here. What was great about it is my patient would show up, they'd do their breath sample, and they were already blowing a positive test. They'd call me and say, do you want them to sit here for 6 hours?
Right.
And I'd say, no,
we already know the answer. Yeah.
Send them home. Yeah. Now, at least they can do it at home. So they're pretty much all home collection.
How is it done at home?
So it's done at home. You're sent home with a bunch of tubes that are, vacuum tubes. And you have the solution, so you're just instructed to
drink the solution.
So you blow into this bag. So it's a special bag, and then it just has a little valve on it that you push the tube in, and then it fills that vacuum tube with.
And then you send the tube off for analysis or whatever.
We actually have the machinery because children said, "Hey, we'll give you the machinery.
Got it.
Please don't." I mean, we ended up buying our own stuff, but we do it in office now. But there's facilities that do this kind of testing. You can send it off, or you can just we test it in our office.
So I'm going off a little tangent because my scientist mind kicks in. But I mean, one of the questions I've got is like, so do you, in your experience, maybe you haven't looked at the data at this level of resolution, but do you really need? So it sounds like you probably don't even need the multiple time points for somebody who's got a severe case. Like you can tell from the baseline sometimes in people.
Yeah. When I just look at their first sample, but I don't have the ability to just look at a first sample now because they're collecting for 6 hours and sending us all
I'm
your
wondering
samples.
more like, an interesting question in my mind is if you just take the general population, what % of people are going to blow a positive on the first sample? Just to get a baseline, like how common is this in the general population? Because I wonder if now that, again, with the proliferation of ultra processed foods and poor diet quality and sedentary lifestyle, is this something that is 1%, 5%, 25% of people may have some degree of this happening? Maybe it's not to the point of clinical symptomology, or they don't know they've got symptoms,
Well, what I would say is I don't know the answer to who would actually just blow a positive before they even drink lactulose. But you can blow a positive by just eating foods that are going to feed those bacteria.
Sure.
So is the person blowing a positive because they didn't prep properly? Because they ate,
but will people who don't have SIBO blow a positive if they've eaten these foods?
Doubtful, I think.
Yeah.
So
maybe the fasting is actually causing some people not to blow up positive because they've stopped eating their normal diet.
Right. And then you give them, and then you give the fuel to the bacteria.
Right.
They'll start creating that, and then it'll get into their blood gases, then they'll breathe it out. But what I'll say to that, as far as kind of answering a little bit about maybe understanding the population, not everyone, it's not common that I'm reading a test when I have someone who I tested and their first sample before they even drank the lactulose is positive.
Mm-hmm.
Just every now and then you'll see that.
You'll see it. You're like, okay.
Yeah. Usually they'll start becoming positive a little later on once it's into the small intestine and those bacteria are creating those gases.
And then my other question was going to be, do you think you need that whole time course, or could you just pick, one somewhere in that 6-hour period that's going to be diagnostic for most people? Just in thinking about how, if you got to the point where you want, say you want to do a research study or you wanted to scale this and test 10,000 people, it's easier to think about one time point than 6 hours worth of time points. You know what I mean? So is it the case that most people who are positive are going to blow a positive at 3 hours?
Like the second or third or
whatever.
fourth.
Yeah. Or is it, do you really need it because it's so variable across the population?
If I were to guess, I would say probably at your third hour, you should be blowing positive. Yeah. But I think it's 10 samples, and by sample 7, you're starting to get into the large intestine.
Okay.
So we have this demarcator for you get this gray line where it's saying, okay, now we're getting a large intestine, and you'll see almost everyone positive on the last few samples.
Even people who don't have SIBO.
Yeah.
Okay.
And so
you don't want to hit that.
Yeah. If you're going over that threshold before sample 7, before you're getting in the large intestine, then you're very likely positive. But if you stay pretty low and then sudden it shoots up, you probably don't have this. So
you really do need some time course to see the pattern.
But if someone has really, really slow transit time, and you maybe they're not going to the bathroom like every 3 days, then maybe you do want to take into consideration those last few samples, because maybe we're still in the small intestine at those last few samples.
So it's not trivial. But okay, so I know, I'm sorry I took us off on that tangent.
Yeah.
So people come in, they do this test, you get a positive.
Yep.
It's I guess if I understood you correctly, you would say it's not uncommon. Like you see this with some level of frequency in your practice.
And once again, we're picking those people to test that you're very suspicious of.
But a lot of people have gastrointestinal symptoms, right? That are sort of amorphous, not always there, sometimes there. So
then how do I choose that person to test SIBO on?
Yeah.
Because I'm not testing it on everyone, because once again, hard to get insurance coverage for that test.
How much is the test without insurance? Do you know?
It's a couple $100, so it's not terribly expensive. So then I'm choosing okay, is this so suspicious of SIBO we should just go there and only do one test and look at one thing?
Yeah.
Or should we do the full stool test that'll give us a lot more data and might hint at SIBO?
Yeah.
Right? And then do we presumptively treat, or do we want to really see for sure?
Right.
So that's kind of how I'm picking that person. The classic SIBO person is going to say, usually bloating, usually kind of, I wake up in the morning with a flat stomach. By the end of the day, I'm having to loosen my pants and, I'm just bloated out here. That's kind of a classic story of SIBO. Or I was never the same since X. So SIBO can definitely be a post-infectious situation.
Okay.
Usually a food poisoning that they've seen in some data has caused maybe an autoimmune response against some neurological aspect of motility in the gut. And then it's kind of the never the same since X, or that bloating that happens throughout the day. And the idea is
you somehow get a bacterial proliferation in the small intestine, and then it's really hard for the body, at least in some people, to clear it.
Mm-hmm.
So you have this chronic overproliferation of bacteria in the small intestine.
Yeah.
And certain types of bacteria are going to be favored there, and they're the methane-producing bacteria that you measure.
Yeah, hydromethane. Yeah. So what do? You got to get them out of there. You got to get them out of there. So I kind of talk about it as first stages. Like the first stage is get them out. And I think that's where sometimes in the allopathic world, in the GI world, they just give rifaximin or an antibiotic.
Right.
And inevitably, everybody has it come back. They might get better, but then their symptoms return.
And does it come back because whatever caused it is still persistent? In other words, diet choices or something like that, or some sort of immune dysregulation?
I think it's more of a functional thing, because we have to come back up and ask the question, well, how does the body keep the bacteria out of the small intestine in the first place? How does that happen?
Yeah.
And so you have motility in the gut. There's a couple types. There's one that we talk about called the mucosal migratory complex, which is kind of microscopic. It's this little kind of wave action. It's kind of a sweep that goes through multiple times a day. That's what we think might be the most disrupted, that doesn't continue pushing things forward. There's the ileocecal valve, right at the bottom of the small intestine emptying the large intestine, that may be dysfunctional in some people. We're not certain about that.
And so would that be bacteria migrating backwards?
Potentially
from the large intestine?
Yeah.
Okay.
Yeah. But usually we boil it down to there's probably a motility thing going on.
Interesting, because I would have immediately gone to either immune function, because I would imagine that the immune system also plays a role in keeping bacterial species in check. Certainly in the gut, that's true, right?
But they're normal bacteria in other parts of the gut, right? Some of them.
Yes.
Right. And they're just in the wrong place.
When your immune system is not functioning optimally, you tend to get overproliferation even of the normal bacteria. So maybe you have overproliferation where they're normally at. That's not a problem from a symptomatic perspective, but contributes to leakage of those things into the small intestine.
That's interesting, because we do not do any direct immune support in the classic treatment. It's clean it out, hold space while you try to address the underlying cause, which is usually motility, and do some gut restoration.
Yeah, and it's probably more than one thing, right? But I mean, the gut really is the largest immune organ in the body, so it kind of makes sense. It
like the gullet tissue and all that stuff.
Play a role.
It may. It's an interesting thing to think about, because I don't know if anyone's really focusing on the immune functionality of that. I guess in a way they're restoring the microbiome in the gut to a degree. As far as the second phase, you either kill them with an antibiotic, kill it with antibacterial herbs, or starve them. You can starve them out by something called an elemental diet, which is just...
That sounds rough.
It's a liquid diet for a couple of weeks, sometimes 3.
Yeah.
And it's just a pre-digested form of protein, fat, and carbohydrate that gets into your bloodstream before it really gets to the small intestine. So you get calories, they don't get anything, and then they just kind of bitter away.
And why is that better than antibiotics?
It's not.
Oh, okay.
Some people
just more difficult for the client.
It's called shared decision making.
Yeah, sure.
So I used to not even talk about that when we were first. I'm like, I just give them all, because some people are like, oh no, I want to do that. I don't care about. I just want to do this. I'm like, really? Is
that a useful weight loss treatment as well? I would imagine.
Well, you can control the calories, I mean, we just give elemental diet to whatever caloric need we want.
Right.
Or that we're looking for.
I guess what I'm wondering, yes, and most people eat more calories than they are looking for. So if you control it, that may be weight loss. So anyways, that's a different conversation.
And sometimes we're not, we're trying to not lose weight, and people who are obviously thin, so we're really having to make sure we're getting those calories up in an elemental diet.
So what's the most effective way to treat SIBO that sticks? In other words, you said antibiotics alone, often it will come back.
Yeah.
Still working on it, huh?
I mean, this is why we whose church of SIBO do you belong to? I think for the most part, you can effectively get it out of the small intestine with whatever kill you decide.
Yeah.
I think Baylor University did a study where they were comparing some of the herbal formulas to rifaximin, to another triple antibiotic and it was kind of like across the board. So I have patients who they'll respond to a pharmaceutical agent, whereas not the herbal, or vice versa. The issue with the pharmaceutical antibiotics is there's one in particular that's still on patent. It's very expensive. It's called rifaximin. And many insurance companies will not cover this medication. It's about $1,400 for a course. And
it probably costs $40 in reality.
Yeah, I mean, we get it through Canada, shipped through India for $200 if the patient really wants it. But it's only FDA approved for IBS-D.
Yeah, okay.
And some SIBO is diarrhea predominant, so you can get that.
And then insurance will pay
And then
for
you can go through the prior authorization and likely get it.
Again, we could spend hours talking about the insurance nonsense.
But anyway, so that's why sometimes we're not really choosing the antibiotics because of a financial consideration.
Got it.
I think I lost your question.
Well, it raises a different question, which is there something special about this antibiotic, or that's just the only one that's FDA approved? It sounds like other antibiotics will work just fine.
I don't know.
Oh,
I mean,
okay.
because metronidazole is kind of like has been on the list, but it doesn't really work that well.
But I thought you just referred to like a triple antibiotic.
Right, and I don't remember what that was.
Okay.
But really, I kind of compare the two, neomycin and rifaximin, to kind of the other herbal formulas. There's several different herbal formulas. I can't remember the triple antibiotic.
And the herbal formulas work pretty well?
They can. There's a combination of either neem, which can work really well with berberine, and then actually allicin, which is from garlic. There's a lot of formulas that really contain more berberine than anything, which is a great gut antibacterial.
Interesting. Yeah, because people talk about, it's interesting that you say that, and there are lots of people who are interested in berberine as a longevity drug, anti-diabetic. Again, just useful to recognize these supplements. It's unclear, first of all, why they aren't regulated, and they are among the dirtiest molecules out there in terms of having many, many, many different biological targets and effects.
And we use berberine for both things, but it's interesting because we use like kind of a whole berberine complex as the antibacterial. We use kind of more of a berberine that's kind of potentized to some of the active components for the metabolic, so.
Right. Yeah, no doubt these molecules, they have effects, and they do work for many of these things.
Yeah, definitely.
So it's super interesting.
So the herbal formulas, and they can be pretty harsh herbs. So sometimes people can have a hard time with them. We have to kind of slowly work up. Get stomach ache from them and stuff like that. So depending on how sensitive you are. But it's really, like I said, shared decision making. It's really what the patient's really wanting to do. Yeah. And because I think we can get there most of the time with either choice.
And again, going back to one of the earlier topics, is you probably want to avoid having to use the antibiotics repeatedly, right? So if somebody takes the antibiotics, clears out the microbiome, maybe they're good for a few months, hopefully longer than that, but it comes back. You want to avoid having multiple courses of antibiotics in the same person if you can. Right.
So with that first, emptying out the bacteria from the small, or like getting them out, most of them out of there, there's still some probably residual, and you're still maybe having some issues that allowed them to get there in the first place. So that's why we like to talk about phase 2, which is dietary. So we remove these carbohydrates. Yeah. So there are different types of carbohydrates that these bacteria really thrive with. So if you can remove those and not give much fuel, but still, start eating foods again, then you can then start working on helping with that motility restoration, helping with digestive enzymes, helping with these things that hopefully will put them in a position to not have it recur.
And how restrictive is this FODMAP diet? Is it something that some people can just adopt and then they stay on it? Or is it
No, I don't think it's a great diet for long term.
Okay.
Because it eliminates a lot of really healthy foods. And because it's an interesting diet because, most people maybe not know that asparagus has quite a bit of fructose in it. So like 3 spears of asparagus when you're on this diet. It's really quantity limited, and there's some other foods that are otherwise healthy with different types of fibers in them that you're eliminating for the time. So for some people it can be very difficult, but there's some good guides out there that, and I think Monash does one. You can actually have a SIBO food guide on your phone, and illegal foods and legal foods. So, it's kind of, they're color coded, but I really try to have patients stay really as low FODMAP as possible for about 90 days.
Okay.
And hopefully, and there's some other types of diets that kind of work too. There's different ones people put together. And then we start expanding. We do all that work to try to get things moving again. And then I like to say, okay, let's just expand, get back to a normal diet.
And does the diet on its own work? Or do you really always pair it with something to clear out the bacteria sort of quickly?
Yeah, I think the diet could work, but I don't know how long it would take. And I don't know how up for it someone is, and how long,
Sure.
How long do they want to eat that way? And are they eliminating other foods that would otherwise be healthy for so long? Yeah, I don't know. I mean, some people have eaten just a carnivore diet.
Right.
And treated their SIBO with that because there's really not any carbohydrates in there. They just did that.
Yeah. And I mean, that's that's really interesting. And also I wonder, you know, of the proponents of carnivore diet or the people who feel like that diet really works with them, works for them, is that because they had SIBO and they started eating this diet and all of a sudden they're like, oh my God, I feel better.
Yeah.
Right. So it's, there's all sorts of interesting possibilities there.
Yeah. So I think it's interesting to think, you know, why do so many people have SIBO?
Yeah. And that's obviously, again, going to be very complex. And I don't know how much research has been done around that, but I'm sure that at least part of it has to do with the change in the what people are eating and how much they're eating.
Right. Yeah.
But probably other stuff in our environment as well.
Yeah. Stress, all those sorts.
Yeah. So something for people to be aware of, though, that it
absolutely.
may be more common than typically appreciated.
Yeah.